Can everyone see that all right?
Okay, so I'm a new provider. I've been working, I did family practice for about 6 years, and I've been doing psychiatric nursing here at Williamson since I think February of this year, so still relatively new. Um, and if you're so excited to have cases, girl, I can set you up. We've got plenty over here we can look at. But
You might be joking, but we are truly excited about this. We will honor you in that request if that's what you want.
yeah, I've got plenty I can send your way. Um, this gentleman, I kind of know his family. I saw his family sees primary care at our clinic, and so I kind of know the family, and they all have some issue. The mother, this is the son, the sister, the father. They come in with odd complaints, headaches, belly pains, that type of thing. So I had never seen him before, except for when I saw him here in clinic. And I don't know how you all present this. I know you all can read all this. I don't know if you want me to read it, or how do you all usually do that?
Just summarize it and then kind of talk about where you're kind of stuck, or what help specifically you kind of want to ask of us, but you don't have to just read it. We got, at least the panel members got the case beforehand. I'm not sure everybody on the call saw it, so it would probably help to just go through and summarize the key points.
Okay. Actually writing up this case helped my thinking a lot, but so this is a 22-year-old. He's been seen at our clinic for primary care. He came to me with quote unquote mood instability, anxiety, depression, ADD. I think actually he uses terms like mood. I have mood instability. I have clinical words that you wouldn't expect for someone to say. He had a long history of lots of medications that he had tried and failed. But as I was writing this up, I looked back and actually looked at the dispense history, and it was like every 4 weeks something new was sent in. So I don't think he had the benefit of a full trial of these medicines. But when he came in, he told me that he had taken Adderall as a child. He had been tried on Strattera and Vyvanse, which didn't really work that well for his ADD. For his depression and his mood instability, Prozac effects are Wellbutrin, Zoloft. I'm thinking somewhere in his history I read that he said Zoloft maybe helped for a little while, but he quit taking it. I'm not really even sure why. He did join the armed forces at one time. He was discharged for suicidal ideation. Okay, there's our med list. I started him on Vraylar, and he said it made him irritable. And I wondered about that. I didn't know, I don't know if the irritability was some type of a mania that he was experiencing. I'm trying to remember exactly how he and his girlfriend have a kind of a strained relationship. And looking back at some of the previous notes of his primary care, he comes in a lot complaining of his anger. So I didn't see, he hadn't really mentioned that to me as much as he did just the irritability. And like I said, after I started writing this up, it kind of showed me that he he has a problem taking his medication. Took Abilify for about 3 weeks. The Vraylar, I don't think he even took for 2 weeks, and stopped because of side effects. So what can I answer?
I think the place I would start, and this is an excellent case that illustrates this, I think, is those terms anger and irritability or mood instability are just such what I like to call vague complaints, right? They are not key to any one diagnoses. And this is, I hear those words, my detective hat kind of comes on, because you really have to kind of go back to try to really understand what the etiology of those complaints are, because they cross so many different differential diagnostic categories and can fit in so many things. And so just looking at some of that history, I mean, I guess my question is let's kind of go back to the drawing board. I mean, he clearly meets criteria for depression and anxiety from some of the screens, but I also see some concerns about trauma history in there, and maybe undiagnosed trauma and how much that could be contributing, which traditionally doesn't respond very well to medicines sometimes in that regard. And I also see some concerns regarding substance use. I know we don't talk about that because it's not to like a severely impairing level, but marijuana use has been clearly linked to a lot of these vague symptoms too, especially mood instability, suicidality, and marked problems, especially in young adults, with executive functioning and attentional concerns. And so I guess as you've tried to tease this out, I mean, do you have a sense of the etiology of those vague complaints, like in terms of what sort of even diagnostic category they really are coming from? I mean, they're incredibly vague. and I I think the challenge with the medicines, because as you said, I don't know if he's not liking the medicines, having side effects, just isn't struggles with the organization to even take medicine. I mean, even the reason why he's not taking it is vague. And so if you were to like say where he is right now and try to take those chief complaints that seem most impairing, do you have a sense of sort of diagnostically what you think is the biggest driver of this?
No.
Because I mean, I would start with, I mean, if he was really, it looks like he started out being really focused on the attention and the ADHD issues, and I would try to say, let's that's a term that people can have. Let's figure out like what type of irritability it is, or what causes the attention problems, because all of those things, even, I mean, if you have scales that he like scored off the charts on depression and anxiety, I mean, I think, and no history of mania, I mean, I would really try to start with just kind of helping him be part of the solution too. I think sometimes he may not have the most emotional vocabulary. Sometimes these are very like terms people get stuck on, and they really can't even describe the feelings, and even sort of helping him give lots of examples is often where I like, tell me what that's like, or how is irritability different from anger? How is irritability different from being sad? Or just trying to really sort of get, tell me an example of what other things were going on when you had that feeling, and trying to do it, because I'm not sure he's gotten a fair trials, but I also don't know that I know what med trial would be best. And I see that big early sexual trauma hanging in the background, and I'll let all the therapists on call talk about that. But that untreated trauma that does not respond very well to meds, if that irritability anger is coming from just a lack of sense of safety, maybe one of those things that might need more therapy than meds in some ways too. And so I will pass on that to the therapists on the call to add their thoughts about that. But I think from what I have, I'm not really sure what the cause of those problems are, and I suspect they're multifactorial, but I'm also not entirely sure it's a med fixing problem at this point, either, or which medicine it would be, because I'm not sure I really know sort of what the etiology is at this point. Well, I'll let other people sort of add their thoughts, but I'm still diagnostically confused, I think I would say.
What is relationship like with therapy? Because I know it said on there that he misses frequently. Does he like miss because he doesn't like it, or he misses because he's, you know, whatever?
He he has a history of therapy at a different location than where I am now. And I even mentioned that to him once because I felt that some of the things that he was talking about might help or therapy could be beneficial. And he said that he has been in therapy for years and that it really hasn't been beneficial. But the place that he was prior to coming here, they bounce around on therapists and counselors. They're in and out a lot. So it's like they get established with one and then here comes a new one on board, and that facility has that issue a lot. And I do remember him saying that now that I'm saying it out loud.
Yeah, that just made me think of it like with what Lauren said about the lack of like sense of safety. If he's not got consistent therapy, he's probably not buying into it too much, especially with missing as well. And we see that a lot, like over here with the college students. They'll say they have they have ADD or ADHD. They have this untreated trauma history, and this stimulant doesn't help with it. It just makes it all worse. So I was just, you know, wanting to know the like history on that.
I think along with some of the trauma pieces, I mean, that takes a much longer time to trust a therapist as well. And so with therapists kind of bouncing around, I bet he's not done a lot of work. And so, you know, I totally agree with Lauren. I think the important piece is going to be exploring this a little bit more and seeing what the true diagnosis is to kind of help him where he's at, because even like Abby said, some medications just aren't even going to touch it if he's not doing the work, because the reality is, I mean, you mentioned at the beginning that he even has, you know, a long history of, you know, his family, right? His family have some of the same problems, and you know of his family. And so when it comes to managing his moods, his anger, his anxiety, you know, it could be a learned behavior or it could be a mood issue. And so we don't know if it's a learned behavior, if it's the underlying trauma, how it's kind of managed within his whole family system. So a lot of areas to kind of just sit down and explore with him. I know for myself, I typically, I mean, I usually work with younger ones, so 22-year-olds are not my forte, but I will say that I work with a lot of young moms. And so if I'm trying to figure out whether it's a mood instability, depression, anxiety, I'll usually utilize some scales to kind of help me differentiate which one is most prevalent at that time. It also opens up some discussion. So like the PHQ-9, which is public domain. And so that helps identify depression and how depressed they may be. Or the general anxiety 7, the GAD-7 can help too.
Both of those screens have been severe, and I look back in the primary care notes, and they pretty much have been on the higher side.
Yeah.
I think he's been in this clinic for about 3 years now.
You know, and from that history, if you're sure there's been no true mania, and that's what you have the most evidence for on the med side, and you have some question in there that he had success with Zoloft, and Zoloft has shown to be good for depression and anxiety, and it actually does have an adult indication for PTSD, although when you really look at the research on that, it's treating the anxiety and the depressive symptoms of PTSD, not the underlying safety. So, I mean, if he truly has had success with that, I think going back to like more of the SSRI type medications, if there aren't other kind of, to really get to an effective dose to might be the best place to start, because you're at least covering that. And then I think a lot of education about how attention problems are coming from trauma and mood and anxiety can be helpful too. And I, he doesn't have a PTSD diagnosis, and he did disclose a history of abuse. I think it's also an opportunity to explore if anyone has talked to him about what even early childhood trauma can impact mood and anxiety. And that's something that gets missed a lot. And if he's already shared that history, that's a big step in the right direction with rapport to even explore it and see, I like to sort of, you can actually do some trauma scales too, but I said, did you know that a lot of I just wonder, a lot of adults who even had early trauma still report struggles with it when they're grown up. Does this still affect you? Do you notice problems trusting people or with intimacy, or do you think about that kind of stuff and just even explore? Because I think sometimes people have tried to repress it so much that often that is really something that they don't even aware might still be affecting them until you kind of let them know it's okay that it might, even though it happened all those years ago. And that might be then the foot in the door if he does say yes to reconnect to therapy, because it may not even be that he knows how therapy could be helpful at this point if he doesn't understand the etiology of it himself.
Yeah, understanding that early childhood trauma is something that I think people have a very difficult time wrapping their brains around, and how much it impacts their body, their dysregulation, their ability to regulate and remain healthy and work towards wellness. So
okay, yeah, that's great. I did not go that direction. But I think I may have mentioned this earlier, I'm not sure. As I was writing this up, I read more into the notes more thoroughly, and he did bring up a lot of issues with his girlfriend. And somebody just mentioned safety and intimacy. So yeah, okay, awesome.
Well, if he's got unhealed sexual trauma, he's probably got zero foundation for romantic intimacy at all. So honestly, like, maybe even talking to someone who is really well versed in childhood sexual trauma would be helpful to him, because he's probably got kind of some inner child issues, kind of going on as well, that aren't helping him create a foundation as an adult.
Okay.
Thank you. And there's some comments too. Abby did put potentially meeting with a therapist who works primarily with childhood trauma, and may be a great option. So that would be a great connection. And then the CBS group, CBS, wow. Maybe his therapy would be more successful if he was involved in more of a behavioral activation type rather than a CBT type. So, really great comments and everything. Do you have questions about that, Tracy?
Well, I was just gonna mention, that is great. Unfortunately, we just don't have a lot of access to that. What about telehealth counseling? I mean, what are you all aware of what options are available there? What groups or anything that we could offer someone who needed more specialized, like with childhood trauma?
Well, so I would want to know what his insurance is and sort of what the providers in his insurance network would be for that. But I mean, honestly, in mental health now, that's been the great success story, I think, for mental health with COVID, is there are so many providers offering teleservices, especially with trauma, that is often something actually that's much more in reach nowadays for people, and more convenient for some people than having to come in person. So I think there definitely probably is even more access to those specialists with tele. And most all health plans cover substantial teleservices now. In West Virginia, they're covered at the same rate as in person. So
okay, great. I will check with his insurance, and they probably will have like a preferred provider list kind of thing. Okay, good.
They'll have like a lot of insurances will have like on their website, you literally can search like the type of provider that you want, or like the type of visit service. So you can go like in person or tele or both or whatever, and it'll like just populate a list. A lot of them even too have like a list of people that are taking on new clients to kind of like differentiate between ones that might be available now or ones that have a wait list.
Great. Okay. Awesome. Thank you all very much.
Thank
Is
you.
it-
And thank you. Go ahead. Go ahead.
Another thing that I found kind of helpful too, because I think, you know, when you're able to prescribe medicines, people often come to you wanting a medicine, right, to fix it all, and sometimes they have trouble articulating it too. And so one of the other approaches I'll take sometimes, other than just trying to educate about diagnosis and etiology and going there, is sometimes I just get stuck in like functionality, right? Like tell me what's the biggest problem for you? What is the barrier that you feel? Are you really, are you having trouble, focusing on, are you having trouble finding a job? Are you having trouble getting organized? Are you having trouble driving? Are you having trouble sleeping? And really kind of go at the diagnostic part backwards from like really explain to me how this impairs your life. How is this anger impacting you every day? And tell me, in your relationship with your partner, how's that anger come out? Because I think, anger and irritability are so vague that like people can't sometimes separate the feeling from the function that is really what disturbs them. Like maybe I'm not having enough sex, or maybe I'm having too much sex, or maybe I just really want to find a job, but I can't say that. And it's easier for me to say I'm tired. And so I think like I sometimes put people in the like, if anger wasn't a problem, what do you think it will help you do? And kind of help them reach like in that future forward thing to try to understand it too. If like going backwards doesn't help with it sometimes. And so I wonder, again, words like anger and irritability just aren't really that helpful to understand either of those concepts. And so I think I think sometimes I'll just say, anger is such a broad term. Tell me what it looks like. Are you throwing things? Are you punching things? Or are you just feeling it on the inside? Or, and just really sort of add to the language that people can start expressing themselves to kind of get to the root of it too. And sometimes just the curiosity that you have about it may also sort of lend power when you say, that's a really important thing. Unfortunately, my meds aren't that good enough for that. These are the things that really help people get to that. And it sells the therapy, I think, a little more too. And I feel like I truly understand it. And that's another way I found to sort of sell therapy to people that might be a little less likely to do that. So that they know I heard them and I wasn't just like denying them medicine when that may have been all they thought, but really sort of saying, I wish I did have a pill for that, but that's not something that medicine helps, is something that sometimes I think gets buy-in for folks too. So
Great.
Thank you so much. And thank you everyone for your great comments, questions, and thank you, Tracy, for that case. And you can do a follow-up with this case, once you've applied some of these actions, or just please keep us informed on, how this patient is doing. And I think we'd all be curious to see how it goes in the future for them. And we wish you luck with that. All right, I'll go ahead and pull up that second case for you. That was a great one. Can everyone see that all right?
It's kind of small. Can you
Oh
pull
no,
it up?
really? I'm sorry.
Elizabeth, you might be able to hit control on your keypad and then like zoom in with the little scrolly thing on your mouse. That sometimes helps zoom in.
Oh, there we go. Is it better?
Oh.
Perfect. Yes.
Awesome. Thanks, Mitra.
Okay, yes, this actually was a new patient last week. And after I wrote up the other one, I thought, well, let's just toss this one in there for the fun of it. Yes, she's a 46-year-old with a long history of alcohol abuse. She said she started drinking off and on around 10. She was sexually abused from the age of 6 to 17. used alcohol into her late 20s, then began to use other substances, opiates, benzos. She didn't start using meth until into her late 30s. Again, she's 46. Has been in multiple detox programs, and pretty much said she came out knowing that she was going to use again, that they just didn't work for her. Let's see, so I don't know that she kind of described herself as schizophrenic, but I didn't get that if she was really hearing what I think would be typical things from schizophrenia. Because she talked about she made imaginary friend when she was younger. And that sometimes she would hear harsh things, but it never did sound like almost like it was her coming from herself. I don't know, but I couldn't determine whether it was true audio or hallucinations. Let's see. She actually had been diagnosed with several things through the years, and I don't have her medication. Go up to that.
I have it there, Tracy, on there.
So you see here what she had failed, and the Vyvanse, Adderall, and the benzodiazepines were pretty much street use. They weren't prescribed medication. And that is her current med list that she came. And I started her on Buspar for her anxiety. She said that she had been given that in the past, but she just took it as needed. And did I mention in here that we did a gene site testing? Is that in there? I may have forgot. So pretty much, she had already been here to the counselor before she had come to see me, and they had mentioned about gene site testing. So that was something that she was interested in. So actually, we did the gene site. I started on the Buspar and did the gene site testing. I want to see her back in 2 weeks. That's a whole other subject about the gene site testing. I'm really interested in hearing what your opinions are on that. And let's see. Yeah, so that's what she had actually asked. You mentioned about symptoms, and I kind of do that sometimes with patients. I say, if I had a magic pill or a magic wand and I could get rid of one symptom today, what would it be? So that way I know which way we're going with if their anxiety, they feel their anxiety is the worst, we'll start there. If depression's worse, we'll start there. And she did say anxiety. So that's started the Buspar. We did the gene site testing. I'm going to see her back in a couple of weeks. I haven't got her records back from the other ones. But one thing. Okay, yeah, I had a question about really diagnosing her, because I really couldn't kind of weed out were those actually, is she hearing voices, or is she hearing that from herself? She had such a low self-esteem that I don't know how to determine the two. And are imaginary friends really visual hallucinations? I mean, she didn't say she saw the person. It was just who she talked to. So questions? Somebody bail me out here.
I have a
It
couple
almost
questions.
sounds like her. Oh, I'm so sorry, Lauren. Go ahead.
Well, so Yeah, I have a few more questions. I mean, that, you know, children, especially with, again, very long history of entry trauma, do often describe imaginary friends and have experiences of that are hallucinatory that really aren't psychotic, but anxiety is actually a very big driver of quasi-psychotic symptoms in a lot of people, as is trauma. And so, you know, I think the way to sort of tease that part out from the pure psychotic piece is one, to understand her cognitive level. I mean, if, you know, when she was younger, that experience was probably more hard to differentiate as being real or not real. But I would query just those questions almost as her. You know, when you struggled with a lot of things, sometimes people feel that it's themselves, and finding out, is the voice coming from outside your head or inside your head? Does it ever feel like kind of your subconscious or your self-talk coming up, or is it sometimes really hard to tell that you think it's someone outside you? And then screening for other signs of psychosis, like truly feeling paranoid and not knowing what's real, feeling disconnected. And you have to make sure you're not getting a trauma sort of dissociative episode with that. But, you know, it's very unusual for comforting voices to be psychotic. And so there was a note in there that some of them she found very uplifting, like, you know, I always hear my grandmother's voice, or a voice of encouragement. Those are rarely psychotic in nature. And so looking through the history of the symptoms and really trying to separate, are there times that they could not differentiate or tell what's real? Were they fearful of being killed or harmed by voices? Can really help distinguish truly psychotic ones from not. And the other challenge here is, I mean, you did describe some periods that are consistent with mania. And so, you know, not only do you have to separate out the voices, but she may have had experiences that were truly psychotic during heights of depression or heights of mania that are real, but may, because she's stable from those things now and not actively psychotic, she may still be perceiving, you know, I think she has multiple things going on that are beyond just that baseline sort of question of bipolar disorder or psychosis. But I mean, she does come from a family history of pretty substantial mental health issues, and some of that may have also been modeled. So, well, I'm sure people have lots of questions, and we can do that. I think the key to figuring that part out, and she already is on an antipsychotic. I mean, the Latuda does provide some degree of protection from the psychosis in terms of the medicine. So I guess even if you do think that it might have been real in the past, it can also help guide where you are right now with what it looks like, because these complex cases, it really could have been true psychosis at one point in the past, but not be true psychosis now, even though they're describing similar experiences. And people that have struggled with a voice or a hallucination, there is history that it morphs. It becomes more of an anxious feature at one point and then truly psychotic at other points, and that's okay, especially given, again, that I mean, that's a 10-year history of abuse she reported to when she was at a lower cognitive level as a child. I even would maybe wonder how much the alcohol use was escape and managing that anxiety and that voice back then too. I'll let some other people have some questions. I wanted to know a little bit more about the anxiety and the nature of the anxiety. Again, anxiety is one of those words I think is so broad. Are we talking about safety? Are we talking about hypervigilance? Are we talking about panic attacks, just generalized worry, obsessive thoughts? So I always like to ask what specific type of anxiety too.
Okay.
Yeah, Lauren, I think you and I must be like sharing the same brain cells right now or something. Because I mean, that's exactly kind of what I was thinking. Like, are these hallucinations or voices she's hearing or anything, are they, you know, more so something that she developed as a child to help her kind of escape or almost even like protect her or something in these moments of abuse? Or like Lauren had kind of expanded on, are they something deeper? Because, you know, with kids, like that can be something that protects them, is to have, you know, something created in their mind that isn't this external environment that they're unsafe in.
Okay, I guess that probably was one of my questions because I didn't know exactly how to differentiate that, but now that you all say the way you all explained it, it makes more sense.
Yeah, I think it's really beneficial to ask more of those questions like Lauren's talking about, because the second highest percentage of auditory hallucinations is PTSD. So you have schizophrenia and then PTSD. And so you still have that trauma piece. And there's so many other things that can impact that too, right? Especially if they've been having it for a long period of time. If it started happening in their childhood, like we've talked about, we've hit on early childhood trauma. But I mean, not to mention like the substance use could have impacted that. I mean, lack of sleep, medical conditions, there's so many other things that could be impacting that. So maybe just having a little bit of a clearer perspective on some of that.
Does she have, or is she, or does she have any interest in talking with a therapist at all, or attending therapy, or has she ever done any of that?
She is seeing a therapist here at clinic, and her history of therapy, I do not recall. I don't see it here on the note.
I was just curious because, you know, that's always something like when you have such a history of abuse that can be helpful that, you know, a lot of people don't think in that direction of seeking out for themselves when they're experiencing things that maybe they think could be solved by a medication route.
How did she describe the anxiety to you now? I mean, that seemed to be what she had highlighted as her kind of most current concern. How did she describe that?
I don't know that I asked questions as detailed as maybe I should have to evaluate that a little more. You know, it just seems like everybody comes in, I've got anxiety and depression, and I don't know that I did a great job on kind of feeling her out on that.
Well, from the medication standpoint, I mean, I think in many ways, and I wanted to ask about the Keppra. Was that for mood, or was that from a seizure disorder, or do you know?
It is a seizure disorder, and she does see a neurologist because I asked when the last time that she had that level checked, and she did tell me she is seeing a neurologist, I'm sorry, for that.
Okay. So I mean, from a medication perspective, just looking at the list, I mean, I think Latuda is an excellent choice. I mean, she mostly has struggled with kind of that depressive aspect of it recently, and it certainly has very good data for depressed phase of bipolar disorder. And if she really has had those manic features in the past, but been predominantly depression, that's a very reasonable thing. It doesn't even sound like depression's an active issue right now. And so it really does look like that dose is stable. If you do sort of dig in though, and this truly does seem to be truly psychotic stuff that's disturbing her, or you're hearing more command hallucinations or super negative ones that seem to be coming from like a depression with psychosis, there's plenty of room to increase that Latuda. And I always love when Angela and the pharmacy team is on, but I you know, that Latuda is a medication that has shown continued efficacy as you increase the dose, and you have quite a bit range to go up on that if needed for that one. I think Buspar is actually a good choice for her for anxiety, especially if the I mean, but it's mostly going to be good for that generalized kind of worry, like day-to-day regular worry. If she describes more like acute panic-like symptoms, or you get more of a hyper vigilant on edge, like I'm always looking at my shoulder, kind of because I feel that scared, not safe kind of trauma type anxiety, there may be some opportunities to look at treating that during the day. Now, prazosin is quite good for the evening sort of hypervigilance and sleep symptoms, which is that autonomic arousal type anxiety. But this is also where sometimes I think that use of more child-friendly medicine has been shown that, you know, things like clonidine, which are a little more sedating, but even guanfacine or Intuniv may help cover some of that hyperarousal type PTSD on edge anxiety during the day. I don't know that she's getting much coverage of that hyper vigilant type coverage during the day. But you certainly have plenty of room to keep working the abuse bar if it's more of a generalized approach. And if you really do feel the mood is stable and you are seeing more of OCD, or I mean there are studies that show you can add, as long as the mood is stable, you could maybe even carefully reintroduce an SSRI as long as the antipsychotic dose is really holding any degree of mood stability, and monitor just really closely for that. But I think figuring out the etiology of the anxiety too, and what type of anxiety it is, might also help guide that a little bit as well. Okay. Were there any big flags on the GeneSight report that were?
I'm not sure if it is back. I didn't work yesterday, and today's been very kind of hectic. I'm usually more put together than I am today. I'll see if that's up. But yeah, I'm interested in your all's opinion on GeneSight. I've read some articles, and I don't know. I'm interested in what your experience has been.
So I mean, I'll just speak for myself. I think it's very helpful in certain people, but I think you have to really understand what its point is. I mean, and again, a lot of times I've seen people kind of use GeneSight in place of actually good diagnosing or revisiting the diagnosis, which is kind of more concerning. And this trauma piece is a big part of it. I've seen lots of people where, I've had all these failed med trials, but you can't really determine if a med trial is a failure if you didn't start with a good diagnostic understanding of it. And so sometimes, I always like to make sure I've revisited the diagnosis before I send the GeneSight, because the GeneSight really should be for when the diagnosis is right, you've explored every which way, and people truly are having unpredictable side effects and responses to medications at known therapeutic doses. Because there are people that absolutely aren't responding the right way, and GeneSight has been life-saving to some patients to say, no, I can't. I mean, I had that side effect because I'm a slow metabolizer or a fast metabolizer, but GeneSight's not magic, and it tells you, and I think patients think that tells me what medicine will work for me, and it doesn't at all. It really is just a fancy way that your body metabolizes it to understand what dose you might need. It doesn't get the diagnosis right, and it doesn't tell you those things. And I think you get a little false sense of security from the green, the red, and the yellow, because if you give a green medicine, but it's for the wrong diagnosis, they're still going to have problems with it, or it's not going to work. And so I think there's a lot of misunderstanding about it, but I mean, I have I think saved people's lives because I really didn't know why they weren't responding, and they knew the diagnosis was right. I knew the diagnosis was right, and it really was that level of detail. But I absolutely think it's a great tool. I think definitely people benefit from it, but I will say I think in practice, I see people relying on it too much, or misunderstanding what it is, and even more patients sometimes than providers just really wanting it, but not understanding that it's not a diagnostic test. And so that's my 2 cents about it. I think it's a tool, and I think it all depends on how we use it. But I don't know. I'll let other people weigh in on that. I think it can be quite controversial, but I'm glad we have it as an option, but I don't think it solves some of the more harder questions.
Okay. I do have her GeneSight pulled up here. I do have the results. Anything specific you were interested in knowing?
Well, I mean, so I think the way to make sure when you use those reports, other things I say is, this is like a one and done. This will never change, right? And even if they give you fancy things, like if you're a slow metabolizer at 2D6 or a fast metabolizer, you will always be that, and it will affect other medicines other than psychiatric medicines too. So you want to know what the actual issue coming from the report is, and not the fancy colors. And so I guess my question is, did she flag as particularly side effect prone at any area of metabolism?
was trying to see, I can't remember, I don't think she's a smoker. I wanted to look and see if she smoked and I can't find it here. Oh, there it is. Let's see. She is a non-smoker. I thought so. No, it doesn't, nothing. Let's see. I don't see anything that's jumping out.
So, I mean, I think sometimes that can be helpful too, especially with anxiety. I mean, one of the things sometimes about anxiety is you over worry about side effects or how a medicine's going to respond or not respond in heightened fashion, either direction sometimes. And so, you know, I do think sometimes those normal reports just really kind of go back to, we don't expect you physically to respond, you know, with more side effects or less side effects, but we still need to understand and get to the root of that type of anxiety or the mood. And that can be, I think, helpful to people too, especially if people have had a lot of med failures or they've had side effects and they're worried about side effects. I think it can be reassuring in that regard. And so, you know, some of her complaints about medicines in the past being too sedating, that tells me that sedating feeling is something that bothers her that's not physiologic, unless the doses were so high. It actually kind of makes me wonder more about anxiety and trauma, you know, that idea of some people get incredibly overwhelmed with sedation because they don't feel safe when they feel cloudy or foggy, and that heightens anxiety from that perspective. So it almost makes me wonder if that report's helpful, because that sedation feeling may have been more functional, right? Not physiologic, and might be part of the challenge. You know, and that's sort of the same challenge with substance use, right? Like even understanding the role alcohol played. You know, was alcohol trying to help her sleep? Was alcohol trying to calm things down? And were there or people that experience alcohol related problems might be terrified of losing their awareness, and the sedation may even be more problematic. So I think it does help understand sometimes even what was disturbing about the side effect, right? You know, is that just a symptom of a larger fear? So I don't know.
Yeah.
I get nerdy about gene site reports, so
I love it. I love it so much.
I get nerdy about a lot of things.
I do too.
There's some of the coolest things. Like we did one here a couple months ago with I think it was Genamind. And the report ended up coming back or whatever. And it was this patient we had seen for a while. This girl had been on 12 million different meds, right? So she, you know, we were really trying to figure out what in the heck was going to work for her. And between me and my attending, we spent maybe 30 or so minutes talking about this dang report, because it was just, they're so interesting to look at. I will say, just to be aware, because this is something we ran into sometimes, and more often than not, unfortunately, patients' insurances can be a barrier to the testing. So just watch out for that. That way there's no like surprise fees or anything like that, because we've definitely seen that come up sometimes over here.
Yeah, thank you for that, Abby. It's even another, like I've done it for something else, but yeah, it's hard to get covered in that. Some of the testing is like 200 to 300 out of pocket, but that just depends on the amount of tests they're doing.
Although I'm and I'll keep y'all updated, but I'm working with Genamind to get West Virginia Medicaid on their list of people that they will accept like insurance coverage for, because they didn't know. They were just like, yeah, we didn't know. We didn't know there was a need. And I was like, well, you people would know if you got more orders, if it was covered. So I'll keep y'all updated. But yeah, just that's something to watch out that doesn't always like, you know, come into our minds when we're considering that. So
That's awesome, Abby. Thanks. That's really interesting. That's good work. Thank you so much. And Tracy, thank you again. Another patient. Great follow-up, would be a great follow-up candidate for a case. Do you have any other questions before we close, or does anybody have comments or anything?
I think those were great cases, and Tracy, I think that's part of the discussion is exploring through our different lenses what we're looking at, and I think that's what helps us us in this group, is because we can provide different lenses at times. So don't feel like you're all over the place. Please still submit cases. I think they were great cases.
Yeah, absolutely. This is a safe space, and thank you for being vulnerable about it. And I think this is great. This is what it's for. It's learning, and other people, I'm sure, come across same questions and complications. So please,
Yeah,
Yes,
they were.
I do appreciate the comments.
and we'll get those back to you as well. I know you guys take your own notes and you're excellent at it, but Mitra and I, one of the things we do is take those post recommendation comments and send it to you back to you with your case. So any other following comments, questions? All right, give you a good old echo pause again. Thank you, everyone. We really appreciate you more than you know, and thank you so much. Go
Yeah, I
ahead,
just
Lauren.
have a quick question. We don't meet on the 20th, correct? We're not
Correct.
meeting again to the 4th. Is that?
That's
gonna be-
correct. Yep. We're meeting again on the 4th. We'll be out for a conference. So we will meet again for the 4th, and I'll get that upcoming emails to you guys for those reminders for the behavioral treatment discussion. All right. Thank you, everyone. Hope you have a good day. Bye-bye.
Bye.